we're just finishing with the long-acting basal backgrounds. And we have intermediate-acting insulin, that's NPH. That's a duration of 12 to 18 hours with a peak of 4 to 12 hours. You can mix short and rapid-acting insulin. Cloudy must agitate. You must agitate it to mix it, and that means just rolling it in your hands like this, not shaking it. Roll it. You can mix short or rapid-acting insulins with intermediate-acting insulins in the same syringe. It provides a mealtime and a basal coverage in one injection, and you can also get commercially pre-mixed or self-mix. Here is a pretty picture for you. This is in your book, and you'll learn how to do this in Adult Health 1 next semester. Know which insulins you can and cannot mix together, okay? Know that.
Can you explain something really quick? Mealtime and basal,
yeah.
Those are two different insulins?
A basal is going to cover you for throughout the day. So they're going to be a longer acting. A mealtime is going to cover you in a shorter duration. So if my blood sugar is up at mealtime, I'm going to take a shorter acting insulin to bring that down short term.
Okay.
And what's that one called?
Mealtime?
Mealtime, okay.
Right. Okay, and your book goes into a lot of detail on this. That's why that the pages 1159, it has the insulin preparation. It talks about rapid acting, short acting, intermediate acting, and long acting. It has a nice chart on it, and it gives you quite a bit of information about the types of insulin and the frequency and the action profile, and how you use them. Okay. So one thing you do have to know about is the way you store insulin. You do not heat it. You do not freeze it. It comes in vials, and it can be left at room temperature for up to 4 weeks, unless the room temperature is above 86. Extra insulin should be refrigerated. You need to avoid exposing it to direct sunlight or extreme heat or cold. Some insulin is stored in pre-filled syringes, and if that's the case, store it upright for a week if 2 insulin types, 30 days for 1 insulin type. One of the things that we used to teach was for a patient to clean their skin with alcohol swabs before they would inject. We don't do that anymore. It's all right for someone to self-inject by just cleaning with soap and water. They don't have to use alcohol. However, if we're giving an insulin injection, we still swab with alcohol. Okay? So if I'm self-injecting, I can clean with soap and water. If I'm injecting someone, I still clean with alcohol. We also talk about, well, let me just go in order here. Typically, we are giving subcutaneous injections. Regular insulin is the only insulin that we can give in an IV. Insulin cannot be taken orally. The gastric juices just kill it. It doesn't work that way. That's what is such a bummer about diabetes, because it's if you have to take insulin, it's all by injection. Administration of insulin, absorption is fastest from the abdomen, followed by the arms, by the thighs, and the buttocks. The abdomen is the preferred site. Do not inject in a site to be exercised. So if you're going to go out running, you probably don't want to inject in your legs, or for your butt for that matter. You need to rotate injection sites within one particular site, and there's going to be a chart that comes up here in just a second. And you also need to think about the patients come into the hospital. There are some sites that are harder for them to reach. So when they're in the hospital, maybe we should be using those sites for them and give the sites that they can reach time to rest. And so let's look, and yeah, there's a great place. So they're going to have a hard time reaching the backs of their arms and the back of the buttocks. So those are better places for us to give insulin. and leave their upper thighs and their abdomen for them to give their own injections. Administration of insulin, we usually give in the insulin syringes, and those are measured off as U100 insulins. Those syringes are marked like that. They usually are orange or have orange caps, although they do come in different sizes, sometimes U50, U30. They are marked in units. They only the user recaps the syringe, no alcohol swab for self-injection, and wash with soap and water. We usually go in at a 45 to a 90-degree angle, depending on the size of the abdomen. Let's see. Okay. Here's a picture of an insulin pen. They are very discreet to use. If the person has poor vision, they can hear the clicks of the pen to help them with the dosage. I know several people that use these. An insulin pump is a continuous subcutaneous infusion. It's a battery-operated device. It is connected to a catheter that's inserted into the subcu tissue of the abdominal wall. It's programmed with a basal rate and a bolus dose that can vary throughout the day. So you program it, just like you program your thermostat in your house to come up at different temperatures during the day. You program this to give you a dose of insulin at different times of the day, but that also kind of locks you in to be eating at certain times of the day. People that have an insulin pump must check their blood glucose level at least 4 times a day. Sometimes testing 8 times a day or more is a common practice. But these are great, especially for younger people that are active. I actually went to Boy Scout camp with a young man that had one of these, and he did great with it. Usually they change out the sites about every 3 days, and he would be able to tell when his site was getting old. So, all right, here's a picture. His did not look like this. He did not have that big bulge right there. His just laid flat against his abdomen. This insertion site is changed 2 to 3 days to avoid site infection. Let's see. So teach the patient about the basal rate, the bolus doses, change the site every 2 to 3 days. And they can be flexible in their diet and the exercise, and pumps should be used in a 24-hour day. So if also with these pumps, if you know you're going to have exercise or you're going to change your diet, you can manually change the pump settings so that you can either dial it up or dial it back. In certain instances, when this young man would go swimming, he could also take it off. Swimming in a lake with a needle in your side is not the best thing in the world, plus the pump wouldn't do very well in the water. So yeah, he could take it out if he wanted to. Problems with insulin therapy, you can very easily go into hypoglycemia, where you get too much insulin and your blood sugar goes down. You can also have an allergic reaction, and you can also have lipodystrophy, which is just a reaction of the tissue around the area where you're injecting. Usually that lipo or the lipodystrophy, which is an atrophy of the subcutaneous tissue, goes away once those tissues are not used. A true insulin allergy is rare. All right. The Samoji effect, I'm going to let you read about in the book. And the next one also, which is Dawn phenomenon, but it's basically Samoji is a rebound effect in which overdose of insulin causes hypoglycemia, and then a release of the counter-regulatory hormones causes a rebound of hyperglycemia. But I'm going to let you read about that in the book. That's not a common thing. And then the Dawn phenomenon is morning hyperglycemia present on awakening, and that's due to a release of counter-regulatory hormones in the pre-dawn hour. Oral agents, these are important. They work on 3 defects of type 2 diabetes: insulin resistance, decrease in insulin productions, and increased hepatic glucose production. And we can use these in combination. So these are called biguanades, and these are kind of common. I bet you've heard of metformin or glucophage, and it reduces the glucose production in the liver. It enhances insulin sensitivity, and it improves glucose transport. It may cause weight loss, and it's used to prevent type 2 diabetes. And it can also, we also withhold this if you're going to have a radiology exam that uses contrast media. And if we withhold this, we withhold it a day or so before contrast is given, and then 48 hours after. And that's important for you to know. Also, one important thing for you to know is that anytime a patient is taking corticosteroids like a prednisone, that's going to mess with their blood sugar. That will increase their blood sugar. So even if they're taking oral meds, once we give them corticosteroids, that may increase their blood sugar enough that we would have to give them insulin. It may be short term until they're off of the steroids, but we will monitor their blood sugar. So know that. The fact that corticosteroids will increase blood sugar.
What did you say before that about 48 hours?
Well, I'm going to cross that again, so hold on, okay? Hold on. Well, here it is. I'm glad you asked that. Withhold, so we're going to withhold, this is with metformin, withhold if a patient is undergoing surgery or a radiologic procedure with contrast medium a day or two before and at least 48 hours after. We're going to withhold the biguanades, and we're also going to monitor the serum creatinine, and that's because of potential renal failure. We're going to look for an elevated BUN. One of the indicators or the contraindications for metformin is renal failure. So if someone already has renal implications, we're not going to give them metformin. That's not their drug of choice. And as stated, contraindications: renal, liver, cardiac disease, or excessive alcohol intake. Metformin is not your drug of choice. Sulfonylureas, it increases insulin production from the pancreas. The major side effects are hypoglycemias. Glipizide, glyburide, and glimepiride. I didn't say that right, but you get the point. It's written out there, so I don't have to say it right. These are all drugs that we can give. Glyburide stimulates the production and the release of insulin from the pancreas. If the hypoglycemia is present, contact your MD. That's kind of a no-brainer. Do not withhold this drug before contrast. It doesn't have any renal implications. Okay. So meglitinides, this is an increase. It increases insulin production from the pancreas. It is rapid onset. It does decrease the blood sugar or causes hypoglycemia. Taken 30 minutes to just before each meal, and actually Starlex is one of those drugs that you give when the patient's tray is right there. I wouldn't give it before. It's notorious for bottoming out the blood sugar, and you should not take it if a meal is skipped. Metformin is a drug that you really need to remember. And then we're not even going to talk too much about these drugs, just read the slides. Metformin is your friend. Did I say that enough?
Yes, ma'am.
Okay. I'm going to let you read these slides about the DDP4. Okay, and those slides too, and that slide also. Okay, nutritional therapy. It is important that your diabetic patients get counseling, education, ongoing monitoring, and interdisciplinary team with a registered dietitian as the lead. Additional team members involved in the management include the nurse, certified diabetes educator, clinical nurse specialist, healthcare providers, and social workers. So nutritional therapy goals, we want to maintain blood glucose levels as near normal as safely possible. We want normal lipid profiles and blood pressure. Blood pressure is important. Blood pressure is one of those things that we're always going to check with a diabetic patient. So normal lipid profiles and blood pressure. We want to prevent or slow complications. Individual needs, we want to be aware of individual needs, personal and cultural preferences, and we also want to maintain the pleasure of eating. Nutritional therapy in diabetes type 1. Meal plan is based on an individual's usual food intake and is balanced with insulin and exercise pattern. And these folks really have to be militaristic, basically, in what they do. They have to have a day-to-day consistency and fixed insulin regimens. They really have to be strict, I guess, would be the best way. This says more flexibility with rapid acting insulins and multiple daily injections and insulin pumps, but they have to be consistent. Type 2, the emphasis is on achieving glucose, lipid, and blood pressure goals, with blood pressure goals being in there. The weight loss, nutritionally adequate meals, planned with a low fat and carbohydrate spacing meals, and regular exercise. So carbohydrates, we want a minimum of 130 grams per day. We want to hit on fruits, vegetables, whole grains, legumes, low fat, milk, monitor with carbohydrate or carb counting exchanges or experienced base estimation. Use a glycemic index and sucrose containing food substitutes for other carbs. This talks about glycemic index. So a glycemic index is a term used to describe the rise in blood glucose levels after a person has consumed a carbohydrate-containing food. The glycemic index of food was developed to compare the postprandial response of carbohydrate-containing foods. And here's a nice website for you if you choose to go look at it. Nutrition, let's see, the fats, we want to limit saturated fats to less than 7% of total calories. We want to limit trans fats. We also want to limit cholesterol to less than 200 milligrams a day. I'm going to let you read a lot of this because I don't want to run out of time here. Alcohol is important because alcohol is important to a lot of people. Limit to a moderate amount. Consume with food to reduce the risk of nocturnal hypoglycemia if used in insulin or insulin, whatever that word is, I can't pronounce it. Just remember alcohol with food. And what is not fair is that moderate consumption is defined for 1 drink a day for women and 2 drinks a day for men. But it is what it is. And so a patient can reduce the risk of alcohol-induced hypoglycemia by eating carbohydrates when drinking alcohol.
Now, I just have a quick question. So with carbohydrates, I thought the goal was to not have a lot of carbohydrates.
Yes.
Because carbs turn to sugar, which then affects...
Well, I think there's a couple of different philosophies on that, and I've heard several. I've known diabetics that go low carb and high protein. And they're quite successful with that. This book is actually, it's going to recommend something here in a minute, and I even forget what they call it. It's something about a life plate or something. I'm a lifelong Weight Watcher, which obviously. Well, maybe it's kept me from being greatly obese, but you can do it a lot of different ways, and those philosophies change from year to year.
Okay.
What's important is to find something that works for you.
Okay. So I know my dad did the low carb, high protein lost a ton of weight, but then ended up actually getting worse.
Right.
And now he's on insulin. So.
Right. And I think the moral to that story is that everybody is different and you have to find what works for you.
Okay.
My scout that was on the insulin pump was a carb counter. And at 14, he was quite good at it. So, all right. So, and that's what's so important about getting a dietitian to come in and teach, because it has to be individualized and it has to be something that the patient can live with. So this is also recommending fiber. It's talking about non-nutritive sweeteners, diabetic teaching, carb counting. It talks about exchange lists. Here it is, the USDA MyPlate method, and then consistency with carb diets. And here's a picture of the MyPlate for diabetics. And let's see, I've got some notes on this. We want to discourage diabetics from using insulin to cover calories. So if they know they're going to go have an ice cream sundae, we're not going to bump up the insulin to cover that. We do want them to be able to say, I know I need to have a snack tonight because my insulin rate or my basal insulin is going to want me to have a snack. I know I need to have a snack tonight. All right, exercise. Exercise is just as important as eating right. We want a minimum of 150 minutes per week of aerobic. We also want some resistance training in there. The benefits include the decrease in insulin resistance and blood glucose. It gives us weight loss, decrease in triglycerides and lousy cholesterol, and an increase in the healthy cholesterol, the HDL. It also improves blood pressure. There's that blood pressure again, and circulation. So it's important to have the patient check their blood glucose 3 times with exercise, before, during, and after. Important to have the patient check their blood glucose 3 times before, during, and after exercise. It's also important to determine what type of activities the patient enjoys when they're considering exercise, because if they don't do something that they're going to enjoy, they're not going to do it. So help them develop an exercise plan that they're going to enjoy. With exercise, they have to start slow. After they get medical clearance, monitor their blood, their glucose. You know, I may have to schedule another one here to get through all of this. If that happens, look for another invite to come. The glucose lowering effect is up to 48 hours after exercise. We exercise 1 hour after a meal, a snack to prevent hypoglycemia. This is important. Do not exercise if blood glucose level exceeds 250 milligrams per deciliter, or if ketones are present in the urine. If ketones are present in the urine, then you don't have enough insulin to metabolize and make energy. That's important. So when should a patient with type 1 diabetes avoid exercise?
It's C.
Yes, because I just told you. Okay, self-monitoring blood glucose. It enables the decisions regarding diet, exercise, and medication. It gives us an accurate record of glucose fluctuation. It helps identify hyperglycemia and hypoglycemia and helps maintain glycemic control. And it is a must for insulin users, and frequency of testing varies. The difference between self-monitoring of blood glucose and a urine dipstick is when you test your urine for ketones, that's at least 8 hours old. When you're testing your blood glucose, that is fresh. You know what your metabolism is doing right there. Here's a picture. That's what they look like. That's a Medtronic device. There's all kinds. I think we've already seen something similar to that. So we teach how to use, how to calibrate, how to test before, 2 hours after meals. That's a postprandial level. When hypoglycemia is suspected during illness, before, during, and after exercise. Know that when we do a finger stick, we stick on the side of the finger, not in the finger pad. There are nerves that we want to avoid on the finger pad, so that's why we go to the side. The patient may use soap and water rather than an alcohol, where we would use an alcohol pad to cleanse the finger. Same for a insulin injection. Nursing assessment, there's subjective and objective data in table 4912. Basically, you want to look at past health history, look for mumps, rubella, Coxsackie virus, or other viral infections. Look for any type of recent trauma, infection, or stress. Look for pregnancy. Delivering infant weight of more than 9 pounds. Look for chronic pancreatitis, Cushing syndrome, acromegalia, any type of family history of type 1 or type 2 diabetes mellitus. Also look at medication use and any kind of compliance with insulin or oral antihypoglycemics. And then look and see if they're on any type of corticosteroids or diuretics or drugs like Dilantin. And look if they've got any surgery or any kind of other treatments that have happened recently or are going to be happening. Planning our overall goals, we want an active patient participation. They have to be compliant. Few or no episodes of acute hyperglycemia or emergencies of hypoglycemia. We want to maintain a normal blood glucose level. We want to prevent or minimize chronic complications. And we want an adjusted lifestyle to accommodate the diabetes regimen. Let's see, identify, monitor, and teach patients at risk. Obesity is the prime risk factor. And I don't know about you guys, but look around and look at our children. We have a true obesity problem going on. Routine screening for all overweight adults and those older than 45. And here is a website with diabetic risk test. Sick day rules. And this one is kind of important. So we want, for acute illness, injury, and surgery, we're looking at increased blood glucose level secondary to counter-regulatory hormones, frequent monitoring of blood glucose at least every 4 hours. We're going to check that by ketone testing if glucose levels exceed 240 milligrams, if our blood sugar is higher than 240. We're going to report the glucose levels exceeding 300 for 2 tests in a row, or for moderate to high ketone levels. Okay, you're going to report it. You're just going to call your doctor. You're going to increase insulin for type 1 diabetes. Type 2 diabetes, the treatment may be throwing in some insulin. This is just during a time of sickness. It's not going to be long-term. So if you're working in a clinic and a patient with type 2 diabetes called in with symptoms, you might want to instruct them that they would monitor their blood glucose every 4 hours. And if it stayed high, you would instruct them to come in. Okay. For an acute illness continuing, they want to maintain a normal diet. If they're able to, they want to increase their non-caloric fluids, drink water, continue taking anti-diabetic medications, and if a normal diet is not possible, supplement with carb-containing fluids while continuing their medications. Okay, a patient with type 1 diabetes calls a clinic with complaint of nausea, vomiting, and diarrhea. It is most important that the nurse advise the patient to, what do you think?
Check the blood glucose level.
Right. Assess blood glucose level every 2 to 4 hours. Very good. Okay, so in an intraoperative period, we're going to run IV fluids and insulin possibly. We're going to frequently monitor the blood glucose. And for a patient that's unconscious receiving insulin, we're going to be alert for hypoglycemia symptoms, sweating, tachycardia, and tremors. For a type 2 diabetes patient, we're also taking oral agents. We're also going to do the same types of thing, monitor their blood sugar, and watch for any type of hypoglycemia symptoms too. For ambulatory and home care, the overall goal is to enable the patient or the caregiver to reach an optimal level of independence. We want them to function. We want them to use a certified diabetes educator, and we want them to establish individualized goals for teaching, and that includes family and caregivers. We want them to be independent. We want to assess a patient's ability to perform their self-monitoring blood glucose and their insulin injections. And you can read the rest of that. Let's see. Foot care. Oral care and foot care, but foot care especially, they need to do a daily inspection, avoid going barefoot, wear proper footwear, and know how to treat cuts. When they travel, they also need to carry their own medication supplies, food, and activity, and just think what would happen to them if they would be caught on one of the interstates that was backed up with the weather. So they need to know how to pack. All right, here's a medical alert. Probably be good to have some kind of identification with them just in case they become unconscious. We need to talk about diabetic ketoacidosis. And this is a bad thing. It's caused by a profound deficiency in insulin, and that is an understatement. Patients come in hyperglycemia, ketosis, acidosis, and dehydration altogether. They are most likely, this occurs in type 1 diabetes. It is acute. These patients end up in the critical care unit, and they are very sick. I think I just lost my cursor over here. Okay, I'm going to have to send out another session here, and I will see you in just a minute, okay?
Okay.